Hi, good evening.
Hi, Lucas. Are you okay?
Sorry, I had some issues joining. There we go. I think it's working now. Okay, hopefully.
It's already some people joining, so you want to just try that you can share the screen, or are you happy?
Yeah, one sec. Let me just get it. Uh, One sec, because it's
Perfect. That's good.
working. Good. Okay,
Yeah,
fine.
we can leave it like this if you want, and I'll
Okay, yeah, that's
start
fine. Don't mind.
on time.
Fine.
Yeah?
Okay.
Okay,
Yeah,
perfect.
yeah, absolutely.
Thank you. Thank you. Good evening, everyone. Thanks for joining us. We'll start in a few minutes, just letting some more people join us, and we'll get started. Thank you. Good evening, everyone, and a very warm welcome to our webinar tonight. I will start with a few housekeeping things, and then I'll introduce our speaker tonight. My name is Marta Jansa Perez. I am the Director of Embryology at Bridge Clinic London, and I'll be chairing this meeting and making sure that everyone gets to follow and to ask as many questions as they want to ask. In terms of asking questions, what will happen during the talk, you can write questions either in the chat box or in the Q&A box that you can see at the top of your screen. And we'll try and address as many as possible at the end of the talk. If we don't get enough time to answer them all, we very much welcome anyone to email us or to call us to discuss any of the pending issues, but hopefully we'll be able to address them all. So tonight we welcome one of our consultants, Lucas Polanski. He's consultant obstetrician and gynecologist and subspecialist in reproductive medicine at Bridge Clinic in London. He has a very extensive academic career of research and publishing, and he also has a PhD from the University of Nottingham. We are very, very glad that he can share his knowledge today about male infertility, one of the things that we don't often talk about, but one that is very, very important. So his talk today is called Understanding the Truth About Male Infertility, and I will let him go ahead and share his knowledge with us. Thank you, Lucas.
Hi, good afternoon, Marta. Thank you very much for inviting me to give this talk. And I agree, it's not very popularized, different reasons, difficult topic, I guess. And it'll be very difficult for me as well to cover everything that was laid out in the brief about male infertility in an hour or under an hour. But we'll try to go through as many things as we can with Q&As afterwards. So as Marta introduced me, I'm one of the consultants working at Bridge Clinic. And the talk will be about male infertility. Sorry, let me just, there we go. So no conflicts of interest that I would need to declare for this. And we'll try to cover a few aspects of male infertility, starting with what it is, how common it is, what causes it, what are the treatments, things that are coming up, new things in the male fertility arena, and also try to dispel some myths about the condition. So in general, infertility is the inability of a couple to conceive or to get pregnant after 1 year of unprotected, regular, frequent sexual intercourse. And that's every 2 to 3 days from when menstruation ceases. And that's what we recommend all couples to try and do if they are trying for a pregnancy. Infertility in general is a very common problem, affecting around 15% of couples, and is estimated it's around 180 couples worldwide, a million couples worldwide, which is a significant burden on all the healthcare systems. And male infertility in particular is the inability of the male to make a fertile, so a woman that has the capacity to get pregnant, over again a minimum of 1 year of unprotected intercourse. So that definition seems to be relatively straightforward and is used worldwide. In the fertility setting, unfortunately, there's a lot of blame assigned either to the woman or to the man, but most of the time it never is anyone's blame. We should not be assigning any blame in this context to either the female partner or the male partner. It is a strenuous, long, difficult journey for both of the partners within that relationship. And therefore, blame should not be something that is exhibited in infertility. Unfortunately, we do often see that, and it can sometimes cause significant rifts between the partners, and potentially even breakage of the relationship. So again, we do not talk about blame, and I would want to get rid of that in the context of infertility in general. When we look at male factor infertility as a only thing that after investigations we come up, it is estimated to be present in around 20% of infertility cases. It can contribute, so there is another factor, apart from male factor infertility, in around 30 to 40% of cases. So overall, we're looking at a roughly 50-50 split between male and female infertility. So again, going back to the previous slide, it never is any one person's, unfortunately, thing that has led to the situation that the couple is in. There are differences between different geographical areas, Asia, Africa, Europe, North America, South America as well, in terms of how prevalent, how common it is. And that is thought to be due to reporting and the availability of the healthcare system, availability of various assessments. So therefore, in some places, Europe, it's probably more prevalent than it is in Africa, but that might be the difference because of those studies and the data that is fed into them. When a couple presents into a fertility clinic, and when we focus on the male side of the assessment, then obviously we do always start with a comprehensive health and sexual history. And then the emphasis in the context of trying to identify a cause is, was there any trauma to the testicles at any point in their life? Was there any surgery, like an inguinal hernia? Not descended testicles, testicular torsion, because all those things can affect male fertility down the line. Is the patient on any medications that could either affect the motility of the sperm or potentially the ability to have intercourse? What is the alcohol intake on a daily basis, on a weekly basis? Is there binge drinking? Does the person smoke? Is it tobacco? Is it weed? Is there any history of any infections in the past? And particularly, we're talking about mumps and TB, because those can definitely affect the sperm production down the line. And also, we can ask the person how often he shaves. Is there any loss of hearing? Because again, those things can lead us to a potential diagnosis, and we can assess a little bit further. We do tend to carry out a physical examination, not always, because if the diagnosis is very clear, or if the assessment won't bring anything, then we don't necessarily need to put that person through this intimate examination. But we generally tend to look at the body shape and form. Is it an athletic type, or is it a very thin person? Distribution of obesity if it's there. And we do examine the genitalia, particularly focusing on the testicular size and volume. And on the picture, you've got what's called an orchidometer, which is different size beads that correspond to different size testicles in the stage of the man's life. We also look at the texture or the consistency of the testicle, how firm or soft it is. Is there any suggestion of dilated blood vessels within the scrotum on one side or on both sides, a varicocele, which again tends to be very common in males suffering with fertility issues. Up to around 40-50% of men can have that condition. And also an assessment should include presence or absence of the vas deferens, which is the anatomical structure that transports the sperm from the testicle through the epididymis into the external world, if it were. Once we've done those initial assessments, we can then look at doing further blood tests that give us an idea how the whole system is functioning, how the brain's functioning, meaning the pituitary and the hypothalamus. So those important centers for governing fertility, both in the woman and the man. And that again might give us an idea what level is affected that leads to the sperm result that we'll come to in a moment, that potentially can be maybe rectified. But again, that's something that we won't know initially most of the time. And overall, when it looks like, when we talk about fertility, male fertility, and its reduction, then we can group it broadly into obstructive and non-obstructive problems, particularly when we're looking at absence of sperm at all. When we talk about how the sperm function numbers are affected, then we can also look for causes that are pre-testicular. So the testicle itself is absolutely fine, but there are other issues with the control of the whole system. So hypothalamic hypopituitary dysfunction, erectile dysfunction, which is a potentially central nervous system condition, whether there is any retrograde ejaculation, which can also be iatrogenic, can lead or can be caused by resection of the prostate due to various conditions, cancer, for instance, or diabetes that is poorly controlled. Or are there any genetic disorders that would have led to complete dysfunction or absence of the cells that produce the sperm? Then we can also focus on testicular causes, which again would be injury, torsion, infections, post-testicular, so anything between the testicle and the sperm coming out of the body, and iatrogenic, which again I mentioned a little bit in terms of caused by potential procedures, caused by chemotherapy as a child, in childhood, surgery, and idiopathic, where we don't potentially find a cause, which is relatively rare nowadays. So this is just a group of things that we obviously ask, and it is generally tailored to the history that we obtain from the person when we see them. Obviously, anything flagged up, we do tend to explore a little bit further. There are some further tests that we can do other than blood tests. Those include genetic testing, include ultrasound scan, just to further assess the potential problem and try to rectify that. There's more and more talk about environmental toxins as being significant in infertility in general, and I mentioned that a little bit towards the end of the talk as well. So before, or one of the first things that we would do before we get to all those causes and conditions and all those extra tests is obviously to get that sperm sample, because that would be the first thing that we would need to do when we look at baseline investigations of a couple that have infertility. Most of the things that are done to the woman, to the female partner, which include blood tests, beginning of the cycle to assess ovarian function, mid-cycle to assess whether there is ovulation, ultrasound scans to assess the shape of the uterus, the number of follicles, so ovarian reserve, tubal patency testing, whereas the men tend to be let off fairly easily with just producing the semen analysis. Now, sometimes it can be on demand, and therefore there can be some issues with that as well. But most of the time, it's a relatively straightforward process. And most of the time, we do obtain the sample through masturbation, be it at home or in the clinic. Obviously, depends on how far the clinic is away from the home, because we want to analyze the sample within the hour of it being produced. In case of production at home or difficulties with masturbation, the sample can be produced during intercourse using condoms without spermicide. So those are generally items that the clinic can supply on demand if needed. Obviously, if that fails, then we're looking at vibratory stimulation, which is more of a specialist way to obtain sperm, or electroejaculation, which is a rare thing, and that pretty much only happens with spinal cord injuries and this is done under general anesthetic, as it tends to be extremely uncomfortable and unpleasant. So this is the machine, how it looks like, and one can imagine where that device will go in order to produce the sample. So once we do get that sample, and there are certain stages that I won't go into, but if there are any questions, I'm sure Marta will be far better at answering those from the lab side of things. But under the microscope, this is what a good sample would look like of human sperm. And these are how it shouldn't look like. So we can see that there's really a plethora of different appearances of sperm that all affect its function. The basic tests that we do to assess the semen analysis are grouped or collected from this or referenced from the WHO 2021, or the most recent edition of the examination and processing of human semen, which has had quite a few iterations. Now we're on the 6th one. And we're looking at the normal range as the lower 5th percentile of semen parameters for men in couples that have started to try for a pregnancy and have managed to get pregnant within a year of unprotected intercourse. And things that we obviously look for are these things with sperm volume, total sperm number, how motile it is, whether it's progressive motility, so is it moving in a straight line, is it going in circles, is it not moving at all, how much sperm is not moving, what's its vitality, and the normal forms, which is essentially the previous slide, how it looks like. And it's a relatively low threshold for that. And some myths and some difficult terminology that probably everyone that has had a semen analysis will potentially at some point come across, particularly if it's abnormal. Then we're looking at, again, aspermia, where there's absolutely no ejaculate at all. One of the more difficult pronunciations is astenoteratozoospermia, where there is, or oligoastenoteratozoospermia, where there's very little sperm, it's not mobile, and it doesn't look normal. So all these things you can potentially come across in reporting. Obviously, if it's normozoospermia, then it will say that all semen parameters are within acceptable reference limits. But these things do tend to come up, and this is kind of in a way a medical way of describing what the semen parameter looks like or are. Other than these routine baseline assessments, there are some additional things that can be done in selected cases. So if we're looking at the sperm grouping together or clumping, then it might indicate that there are some anti-sperm antibodies, and that might be due to either infection, trauma, or after vasectomy reversal, because that can cause the body to develop antibodies that will then attack semen and cause it to clump together, affecting fertility. Things that are recently coming up, so novel stuff in male fertility area, is DNA fragmentation, which we'll mention a little bit in the next slides. We're looking at genetic assessment, particularly in the context of very poor sperm parameters. And what we mean by that is anything probably less than 1 million sperm per milliliter, ideally on 2 samples, because the sperm parameters can be affected by things like an infection, feeling very unwell, alcohol in consumption, and therefore if we've got poor sperm parameters, we do tend to repeat it. If there is no sperm, we can repeat the sample fairly soon. If the sperm parameters are borderline / moderately affected, we would want to leave at least 3 months in order to allow for the sperm production or sperm cycle to take place, purely because of how long it takes to produce one spermatid, so one sperm sample, from nothing, from a baseline cell to the sperm that has the potential to form a pregnancy. And the genetic testing that we do carry out in these cases is karyotype, so assessment of the chromosome composition of the person, cystic fibrosis screening as being affected by it, does carry a risk of absence of the vas deferens, and therefore obstruct vasospermia. So there's no sperm, there's no means for the sperm to leave the testicle to then be assessed in the outside world. And Y chromosome microdeletions, there are certain regions within the Y chromosome or the male chromosome that are associated with sperm production, and they're grouped in the AZF region as A, B, and C areas that we are interested in particularly. We mentioned the hormonal tests. Now, these are relatively older ones, which was post-coital test, essentially whether there is any live sperm after intercourse. We don't tend to do those anymore, but that's something historically that has been done, and some places in Europe still tend to do that occasionally, particularly with difficulties getting pregnant for a long time and when nothing else can be found. We want to have a look at a urine sample as well, and that's either to exclude infection, or if there's no sperm in the ejaculate, is there any sperm within the urine sample, which would indicate retrograde ejaculation? So the sperm, rather than coming out through the penis, goes back into the bladder. So that's something that we again tend to do in selected cases. We can do an ultrasound to assess for the size of the testicles. Are there any cysts? Are there any abnormalities within the testicle? Is there varicocele that we can't feel but is apparent on ultrasound? So the dilated blood vessels that we mentioned. Or ultimately, we can end up doing a biopsy of the testicle to see, is there any cells that could lead to development of sperm, or are there any sperm, early spermatids, early sperm cells that don't make it to be coming out of the penis during intercourse or during masturbation. So those are the kind of more invasive and very rarely done tests, but we do have that availability. So once we've done those tests, we can talk about test hit rate. So if we do that test, how often are we going to find something? Well, from the genetic side of things, we're looking at chromosomal defects in around 15% of couples with severe male factor. And in a general population, normal healthy population, that proportion is 0.6. So there's a significant concentration of men that have got very poor or no sperm, that have got some sort of a genetic abnormality, be it an extra chromosome, so Klinefelter, or Klinefelter syndrome, or the Y chromosome microdeletions, or cystic fibrosis, which can affect up to 1 to 2% of the population, Caucasian population. Historically, the post-coital test was abnormal in 10% of the couples. When we do a testicular ultrasound, that tends to be have a relatively good hit rate, with up to 40% of men, infertile men, having some abnormality, and it doesn't have to be that severe, severely abnormal sperm sample to come up with a result. And the most common abnormality are those dilated blood vessels, either unilateral, and most of the time it's the left side testicle that's affected because of the anatomy of that testicle. And again, fairly infrequently, so in 0.5%, so we're looking 1 man in 200 might end up being diagnosed with testicular cancer purely because of infertility. And that proportion is 100 times higher than a general healthy population. So again, it's something worth bearing in mind. So we mentioned DNA fragmentation as a test that can be done to give us a little bit more information about the sample that we're seeing. And this test, again, is a relatively new test. In the last decade, it's coming into play. There are different ways of assessing sperm through this test, but most of the time, these tests, unfortunately, destroy the sample that is being analyzed. So in a way, doing that test only gives us information about the sample that we're actually looking at. We can infer from that the all, or if we were to do repeated samples over a short period of time, they're all going to be affected. And the most likely cause of high fragmentation of the DNA, meaning where the structure of the DNA, the genetic material, is interrupted and broken in places, and therefore can lead to errors when the egg and sperm meet for that genetic blueprint of the embryo, which then can lead to either failed IVF treatment or miscarriages, recurrent miscarriages sometimes, or later losses. The DNA fragmentation test is not something that we do as standard when it comes to male fertility assessment, but we do tend to at least inform patients about having it potentially done, particularly when the couple struggles with recurrent miscarriages, because there is a little bit more evidence for high DNA fragmentation and miscarriages rather than high DNA fragmentation and IVF or ICSI treatment failure. But again, because it's a relatively new thing, still data is being collected, and potentially in years down the line, we might actually be proven wrong. And actually, high DNA fragmentation might also be associated with poor outcomes of IVF treatment, particularly if the standard assessments, so the normal morphology, motility, appearance of the sperm is normal, because that can still be preserved with high, even high, very high DNA fragmentation. So from the IVF side of things, again, when you look at different outcomes from fertilization rate, pregnancy rates, and these are a group of patients that were grouped into IVF and ICSI. So IVF, where the egg and sperm are left alone in addition, allowed to fertilize on their own, versus ICSI, where one single sperm is selected and injected into the egg. Then those things tend to be similar in the groups with normal DNA fragmentation, which is thought to be less than 15%, moderate 15 to 30%, or high over 30%. But when you look at miscarriage rates, then those tend to be significantly higher across all groups of patients where the DNA fragmentation was moderately raised, or definitely when it was significantly raised. So again, there is that evidence to say, obviously, DNA integrity does help to make sure that the pregnancy can continue safely and lead to a genetically normal embryo. And then, obviously, once we've done all those things and we've done those tests and we've come up with some diagnoses that we give the patient, the most important thing that the patients and the couples will want to know is what can be done about it. Well, that's potentially the most difficult thing, because sometimes we actually can't offer any treatment other than IVF, most likely with ICSI treatment, so where that sperm is injected directly into the egg. Provided the endocrinology or the endocrine function, meaning secretion of testosterone by the testicle, is not affected, and the libido is normal, but there is no sperm, no additional treatment may be necessary. So no hormonal supplementation, because that won't make anything, won't change anything, but the long-term outcomes of these patients, particularly from a heart point of view, cognitive function, tend to be normal. If the endocrine function or secretion of the testosterone is also affected, meaning it's very low or non-existent, then we would be looking at supplementing the testosterone in order to give that person the quality of life that they need and also reduce their long-term risks. So it's similar to hormone replacement therapy in the woman, where when the ovaries fail early, we do want to supplement those hormones that are needed for those vital functions. If we're looking at poor sperm parameters, then even with those patients, there is a chance of spontaneous pregnancy provided everything else is normal. And some data suggests that if we're looking at a low concentration of less than 2 million per milliliter, around 8% of couples can still get pregnant within 2 years of regular intercourse. So there is always that possibility. It only takes one. That is a very, very true saying in infertility. We always advise lifestyle changes, be it to one or both the partners, and most of the time if the couple takes up some good lifestyle habits, then that has a significant benefit for them overall and their pregnancy as well. First thing that we do want to advise them if they smoke is to stop it, because smoking can affect all semen parameters, including increasing the DNA fragmentation, because it increases the free oxygen radicals, which do damage the DNA and can therefore lead to that higher risk of miscarriage later on. Alcohol tends to affect motility. Various drugs, be it legal or illegal, can similarly affect all sperm parameters, but also can potentially affect sexual performance and therefore not being able to have intercourse on a regular basis. Weight, particularly being significantly overweight, does affect the endocrine function of the testicle, therefore potentially reducing sperm parameters. So we advise men to lose weight. And similarly, if you're looking at the NHS funding criteria, in some places they would not fund IVF treatment if a man has got a BMI over 35. So that also is being taken into account. In some cases, we would advise various supplements, and those are some of them mentioned on the right side of the screen, which we would be looking at L-carnitine, antioxidants, which is coenzyme Q10, vitamin C, E, folic acid, zinc, and selenium, which are the most important microelements when it comes to sperm production, particularly DNA integrity. We do advise, and we should be advising all couples that are trying for a pregnancy, that the man does not wear tight underwear, does not wear or keep the phone in the front pocket of the trousers, does not put a laptop on his lap, no hot coffee, no hot baths. And obviously we're talking about also no various supplements when going to the gym, because even though they say they don't have any anabolic steroids, they might not be mentioned on the label. And all these things do affect sperm quality, sperm production. And fairly often, if someone has had a febrile infection, so flu, COVID as well, then those sperm parameters, if we were to test the sperm sample within the first few weeks after that, they will be very poor. So again, we would want those 3 months ideally to get a new sperm that's from a different batch, if it were, to test it. And again, activities depends on what the person does. Prolonged sitting. So lorry drivers, unfortunately, are significantly affected by male factor infertility because of this prolonged sitting, increasing the testicular temperature. There's a reason why the testicles are outside of the body, because the temperature needed to produce the sperm is around 2 degrees less than the core temperature. So anything that brings it up, unfortunately, affects the sperm parameter quite considerably. And medical management that we sometimes do employ, again, depends on the cause, but we can use some anti-estrogen, so clomiphene or aromatase inhibitors, to try and trick the brain into producing a little bit more FSH, so the hormone that is related to testicular function, and therefore boosting the sperm production. Nasal testosterone can also be used again when we're needing to supplement it, or depot injections, but that tends to be only when the endocrine function is failing, and all these various supplements that we mentioned as well. When we're looking at no hormonal drive to the testicles, and that can be a genetic condition associated with anosmia, so when there's no ability to smell, then giving gonadotrophin injections, so hormones that would drive the pituitary to produce the FSH and LH to then produce the sperm and testosterone, are used with relatively good efficacy. But again, it's a very small proportion of men that would meet this criteria for this treatment. From any anatomical abnormalities, be it when someone's born with absence of or part of the, be it plumbing is missing, then there are different surgical procedures that can be done in selected centers where things are essentially reconnected, where with, again, varying success rates of around 30%. When we're talking about presence of varicocele, so dilated blood vessels, which also increase the testicular temperature, increase the free oxygen radicals within the testicle, they can affect, obviously, fertility. Removal of these, so either through microsurgery or through interventional radiology, where dye is injected into the blood vessels to block them, can increase the sperm parameters and also can increase the chance of spontaneous conception, can also reduce the DNA fragmentation. So overall, the evidence for it is poor, but there is more evidence getting collected that actually says, prior to even IVF treatment, if the varicocele is present, we should be recommending men to have this procedure done. Particularly if there are symptoms of this pain, dragging sensation, it's very large, then that in itself would be indicated. And worst case scenario, when we're looking at needing to obtain sperm through a surgical procedure, then that can be done either with a needle through the skin of the scrotum into the epididymis, which is the storage tank of the sperm, or directly from the testicle during a surgical procedure. That's kind of what we would potentially consider in some couples. Now, if none of these things are necessary, and we've got purely need for or desire for pregnancy, then we would be looking at intrauterine insemination, where prepared sperm is injected directly into the uterus around the time of ovulation. But for that, we would ideally want at least 1 million of motile sperm, with a relatively, again, good success rates of around 50% pregnancy rate after 9 attempts. But again, it would depend on the female age, whether the tubes are open or not, and any other history that might indicate that this would not be a good treatment for them. Then we're moving on to IVF, where we're looking at 50,000 to 500,000 of motile sperm for it to be successful, or ICSI, where we only need pretty much 1, and then potentially higher magnification in, again, selected labs, selected cases. So the gold standard for obtaining sperm through a surgical procedure at the moment, again, selected cases where there is no sperm within the epididymis, within the storage tank, would be a microsurgical testicular sperm extraction, or micro-TZ, which tends to be done by urologists or andrologists, where under general anesthetic, the testicles essentially splayed open like a book, and under magnification, the swollen tubules are extracted, and the likelihood of obtaining sperm in that case is much, much higher than with just a blind biopsy. So this is something that we do consider in azoospermia, where the hormonal function tends to be relatively normal and non-obstructive cases. Once we have gone through that whole process of obtaining sperm, potentially with some difficulty, we obviously don't want to discard it. We want to keep it. Unfortunately, we do have the availability of sperm freezing, and actually that's a very effective process. However, that process of freezing and thawing does reduce the sperm quality afterwards. So we're looking at up to 50% drop in the parameters that we've mentioned. If we do obtain the sperm from the testicle itself, then that tends to survive the process worse. So there's more loss of those cells, purely because they're not fully capable of surviving they're not normally mature sperm cells. Therefore, their survival tends to be worse. But the good thing is, it doesn't matter how long that sperm stays in the freezer, because actually, whether it's thawed after a week or after 10 years, it tends to survive the same. So in a way, that's good news for long-term survival, particularly if we're talking about childhood or adolescent cancer patients, cancer patients, where we can store that sperm in their teens, that then can be used in their 30s or 40s or 50s to have biological children. So in a way, that's all very good, thanks to the newer ways of freezing sperm in the lab. And reassuringly, outcomes of pregnancies with IVF or ICSI with fresh or frozen sperm are very similar. Similarly, when we're looking at intrauterine insemination, there tends to be very little difference in those success rates. Obviously, factors have to be taken into account. In this case, it's not just the man, but it also would be the female partner. I didn't mention an option of donor sperm because that always is there, but in some cases it's not something that the couple would want to explore. So it does have to be a frank discussion between the clinician and the couple. Once we've done all these tests or potentially gone through the treatment where no sperm is obtained, what then? And some couples would not want to go down the route of the invasive procedures purely because they do carry risks. and they decide for donor sperm or a sperm from a different person, is in a way ordered through a catalogue, and then used for either IUI, IVF, or ICSI, depending on the quality. And one of the final thoughts about male infertility, because we've only focused on the physical aspect of it, but that's not all, because there's a significant psychological burden on the couple, which we mentioned, but also on the man. So that's something that tends to affect some men quite significantly, because the belief is that the man should not be at fault at this, mentioned again earlier, and therefore having that diagnosis of no sperm tends to affect them psychologically quite substantially, and they might struggle. Therefore, psychological support, having that option in these cases, particularly in the severe male factor infertility, is a essential part of treatment. We mentioned that these men with a very severe factor or no sperm are at a substantially increased risk of testicular cancer. And that's 5 to 8% where there's no sperm. These men can have testicular cancer. So the ultrasound scan, which we mentioned, would be the investigation of choice in this case. And a final comment about COVID-19, which we kind of all are living with at the moment, if it were. It can directly affect the cells that sperm produce as well. That can cause a cytokine storm. That's why patients end up on ITU. But all of that, that kind of soup of various chemicals, does affect the fertility and the sperm production, sometimes permanently, but most of the time it's a transient drop with then a return to normal function. But the more severe the infection and the longer the infection, the more severe the drop will be observed. That's what the kind of data has shown on this. Again, I'm sure some or most of you have heard about the infertility or male fertility pandemic, where men are going to die out in the next 50 years. Hopefully that's not going to be the case, but there is definitely a observable global reduction in sperm counts from around 113 million per milliliter in the 1940s to 66 million in the 1990s. And the acceleration or the decline tends to be more recently, with only around 1.2% drop pre-2000s to then a 2.5% drop per year more recently. So it is a concerning finding, but it has to be taken with a pinch of salt, because again, it depends on the lab assessments. We're having far better equipment than we had in the 1940s, but things that most likely do affect this are the environmental factors. So the pollutants that potentially the people in the 1940s were affected or exposed to, that can then cause damage generations down the line. The promising things that are coming into the field, now only experimental and only on animals at the moment, are potentially creating new gametes, new sperm from things like skin cells, to then gene editing these gametes to the desired physical factors that the couple might wish to. Now, this is hopefully many, many years down the line, and it's a completely different discussion with a lot of ethical dilemmas and pitfalls. So in a way to conclude, male infertility is a common condition. It doesn't only have physical manifestations, but it can have significant and profound psychological effects on the man and the couple overall. There are some different options of investigations and treatment that we can offer to these men. And reassuringly, from a pregnancy point of view and a long-term survival point of view, these things are very good and very reassuring. So thank you very much. And I will take any questions if there are.
Thank you, Lucas. Thank you for this amazing and thorough overview of all things male infertility. I'm sure people have found it very interesting and very helpful. There are a few questions which I'm going to ask to you in a minute, but before I will say, I'm also very glad that you mentioned the psychological aspect, because it's something that we often also ignore, particularly for men, and just to say that we have support in the clinic in the sense that all our staff are trying to support patients, but also our counselors are available for patients at any point in time. And we have both a male and a female counselor if people are interested. But I'll get into the questions. The first one is about something you mentioned earlier on about loss of hearing might be an indicator of some male infertility problems. So the question is, what would that indicate if someone had loss of hearing?
So loss of hearing, loss of smell, loss of motility tend to be conditions affecting the cilia, so the sperm tail, if it were. So genetic conditions associated with that can sometimes manifest with loss of hearing. So normally what we do in these cases, if obviously we do the tests and nothing comes up, we potentially would refer to a geneticist, genetic counselor for those tests to be done. Rare, those are rare, very rare conditions.
Okay, excellent, very helpful. And the other question that someone has put in the chat, is there a remedy for chromosomal abnormalities? If someone has a karyotype and comes back abnormal, is there a solution for that?
Yes and no. It depends on what genetic abnormality or chromosomal abnormality we're talking about. If we're talking about chromosomal abnormalities where part of it is inverted, so flipped round, then what can be done again following genetic counseling and obviously a detailed assessment of that abnormality, couples can undergo what's called pre-implantation genetic testing. So that's a IVF process. So the preparation for this procedure would be a IVF with ICSI, so one sperm directly injected into the egg. Embryos are being cultured, and then those embryos are being biopsied. So there are cells taken from that embryo, and they are assessed for presence or absence of that genetic abnormality. The embryos that are deemed normal in that assessment are the ones that the couple can use for treatment in order to essentially select that embryo that is normal. If we're looking at genetic abnormalities within the azoospermia region of the Y chromosome, again, it depends which part of it is abnormal. In some cases, there is absolutely no chance to get sperm because there is no production of sperm whatsoever. But in some cases, doing the surgical sperm retrieval, so the microteasy, 50–60% of cases we might be able to get sperm, and that sperm tends to be usable for ICSI or ICSI treatment in this case, but all the male children will carry that abnormality as well. Okay, so purely because men have XY, and if we're looking at a sperm that has the Y chromosome and it's put into an egg, that child will carry that genetic abnormality with it. So again, potentially selecting sex might overcome that if we're looking at just getting X sperm to create a girl. So there are things that we might overcome with these treatments, but some cases where there is absolutely no sperm, then there isn't anything that we can do in this case other than a sperm donation at the moment. There's
Thank you.
I think, as well.
Yes, I was going to say, if the person who has the hand up, would they mind just write the question in the chat box or in the Q&A, then I will ask it on their behalf, if that's okay. But in the meantime, if you can do that, I will ask you another question, which is to do with antioxidants and supplements, because there's lots of talk out there and lots of providers of that sort of thing. So I think it would be of interest to people whether that's something that you would recommend to anyone trying to conceive, or which cases would you think that you would recommend certain supplements and how to go about them, because there are so many.
Yes, that is true. And I think each and every one of them is marketed differently and tries to kind of play on people's emotions as well. I think if you look at the data and the evidence, kind of two things really stand out. One of them is zinc and selenium as the microelements, and vitamin C. And those things, provided they're contained within the supplements, tend to be all that is needed. Obviously, we're looking at healthy diet, lifestyle modifications as well. That's about the evidence. Now, again, it can be skewed this way or that. So it is just a matter of assuring that those things are contained, sticking to it, and the important thing is, once you start taking it, don't expect to see a result within 1 to 2 weeks. Okay, because as with everything, unfortunately, human reproduction related, it does take a few months, 3 at least, before any observed effects can be noted on a sperm sample. Similarly, when we talk about vitamin C, no more than 1,000 milligrams a day, so a hefty dose, and also not for a very long time. So probably 4 weeks would be enough to see an improvement in potentially the DNA fragmentation, which is another thing that may be considered. So I think preparations that you'll come across, Proxeed, one of the most common, well marketed, and containing all the necessary things, or things similarly as simple as Wellman Boots fertility vitamins as well. They do contain those things as well. So again, I won't name and shame what you should be taking, but again, provided those 3 things are contained with them, that should be enough.
Lovely, very helpful. Thank you. 2 more questions, if everyone's still happy to stay, because I think it's relevant to all. The first one says, my partner initially had a few sperm in his samples and then 2 samples had none. Why could this happen?
So if we're looking at the initial sample having few sperm, it indicates a severe problem. So there's a severe male factor infertility. And it can either stay for a long time on a steady, stable level, or potentially an infection, a little bit of lapped up on the lap prior to the repeat sample might mean that there is nothing there. And that's something that we do see in the very severe male factor infertility cases. So it, in a way, is potentially a natural progression of the disease as well. Meaning that's what unfortunately happens with time. But it also might be that it's a reversible thing. So because of a small infection or something like that, that might not have necessarily been apparent. That poor sperm production was even further affected, and therefore there is nothing on that repeat sample. So it's either explained by the disease, the cause of it in itself, or something that happened on top of that already severe problem. I hope that answers the question.
Yes, I hope so too. Thank you. It's hard to answer individual questions without seeing medical history, but yeah, thank you. The next one is the one that had the hand up, and it says, is it possible to correct the low motility in sperm and abnormal morphology? If yes, how? My husband does not drink nor smoke. He's athletic and no infection. Also, I have gone through some tests and everything is normal. Must I go through IVF?
It's again a difficult thing. I think there is no must in anything at the moment. I think it would have to be a choice ultimately, and depends on how long you've been trying as well. If everything's normal, and again depends on your age, kind of the data shows that if you've not conceived within 2 years, IVF would be your best chance of pregnancy. As I said, there always is a chance, unless there's no uterus and no testicles, then essentially the chance is 0. But otherwise, there is always a possibility of a pregnancy. And when we talk about, is it possible to correct? Again, it depends on what the other assessments do show. So how low the motility is. Again, if it's borderline, does that actually matter if we've got a completely normal concentration? Maybe yes, maybe no. And it definitely, again, goes down to if he's athletic and going to the gym, does he take any supplements? And even though they might not say that they contain anything that could potentially affect it, we do advise men to stop it altogether. Because we've come across different problems with supplements that tend not to have anything on the label, but actually do affect sperm production because they do contain some anabolic steroids. So therefore, doing those blood tests, having a look at the LH, FSH, and testosterone level, probably would be something to consider if those abnormalities are persistent and severe. Other than that, loose underwear, no cycling, no tight cycling trousers, no laptop, no phone in the pocket, because that's a notorious thing that people don't realize can affect it, but it can. And that's probably it at the moment based on that bit of information. And again, where's the varicocele? So that clinical assessment is their dilated blood vessels, because again, with everything being normal, that can actually be the one thing that will be abnormal, that actually could affect all those parameters that you mentioned.
Okay, thank you. So we'll do the last question now, which says, is it safe for males to take Clomid long term, i.e. for more than 3 months?
I think the data is not particularly clear on that. I think if we haven't seen any results after 6 months of being on Clomid, there is no point of continuing it, because it will not restore sperm production. It might increase testicular endocrine function, so the testosterone may rise, but if the sperm production doesn't go back on it, doesn't start or increase, then from that point of view, it's not something that you should continue in the long run. But again, it depends on who initiated it, what the actual reason for it was. Because if it's just for testosterone production, there are safer alternatives, testosterone essentially, that could be then used long term rather than Clomid, which is not licensed for that.
Excellent, very helpful. Thank you very much, Lucas. We'll have to stop here, but as I said before, if anyone has any further questions for Lucas, please email us. If you want to book a consultation with Lucas or any of our other doctors, sorry, I can't talk anymore, please get in touch. We'd be very happy to help anyone who has any concerns or worries or trying to conceive. But thank you, Lucas. It's been an amazing session. And thank you everyone else for joining and for the very interesting questions. Thank you.
Thank you.
Bye, everyone.
Have a good evening, everyone.
Bye.
Bye-bye.